Good morning, Dr. Boulton.
Good morning.
You can hear me then, good. Can you see me?
Yes, I can see you, yes.
There's a slight lag, I think, on the connection. You're at home, are you?
I am indeed.
And you're there with your wife?
At the moment she's out, but she's around.
But in the room at the moment, just yourself then?
Yes.
Now you're talking to Aldwych. There's a select group of people here to listen to what you have to say, but your significant audience is that beyond this room. They'll be watching remotely, YouTube or live stream, and there will be something like 100 or thereabouts or more people who want to hear what you have to say. So that's your audience. The questions are going to be asked by Ms. Scott. She is also asking them remotely, so we'll just have to hope that the connection is maintained. We've managed pretty well so far. There's been the odd hiccup. If it happens, please forgive us. And in a moment or two, I shall ask Mary to ask you to take the oath. Mary? And then Ms. Scott will ask the questions.
It is actually an affirmation which I've agreed to give.
Yes, the oath is a global term.
Please state your full name.
Frank Ernest Boulton.
And repeat after me. I do solemnly, sincerely.
I do solemnly and sincerely.
And truly declare and affirm.
And freely declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Ms. Scott.
Dr. Boulton, I'm going to start by asking you some questions about your career. So you were a trainee pathologist at St Thomas's Hospital from 1967 to 1970, and then took up a post in 1971 as a senior registrar in hematology at the London Hospital. Is that right?
Correct.
You then became a senior lecturer at the London Hospital Medical College, a post you held from 1973 to 1975.
That's correct.
You then became senior lecturer and honorary consultant haematologist at the University of Liverpool and Royal Liverpool Hospitals between 1975 and 1980. Is that correct?
That's correct. The difference in the senior lectureship is that in Liverpool I had NHS consultancy, whereas at the London I was not quite of the consultant status, but I was an honorary consultant at Liverpool. And
I'll come back in a moment and ask you a little bit more detail about those posts. And then you moved to Scotland and took up a post as a consultant haematologist at the Edinburgh and South East Scotland Region Blood Transfusion Service based at the Royal Infirmary of Edinburgh, a post you held from 1980 to 1990, albeit you became Deputy Director of the Transfusion Centre in 1982. Is that correct?
Correct.
And then in 1990, you moved to the Wessex Regional Blood Transfusion Service in Southampton as medical director, a post you held until 1995. And then when the National Blood Authority took over all of the regional transfusion centres, you remained working, as it were, in Southampton, but your post changed to consultant haematologist at the National Blood Authority. Is that right?
That's correct, yes.
And you retired, I believe, in 2006.
Yes, yes.
You've also been a member of a number of advisory committees and working groups. Just to pick out a few of those, you were a member of the Standing Advisory Committee on Donor Selection, and that was a UK Blood Transfusion Service and an NIBSC committee. You were a member and then became secretary and then became chair of that committee. Is that right?
That's correct. And the full title that evolved during my time there was the Standing Advisory Committee on the Care and Selection of Blood Donors. The caring bit was important.
You were also on the Standing Advisory Committee for the UK BTS NIBSC on clinical transfusion medicine. You were a member of the coagulation factor study group. You were a member of the SNBTS, Scottish National Blood Transfusion Service Ethics Committee, Clinical Research and Investigations. And you were a member of the SACTI Working Group on VCJD, at the SACTI Advisory Group on Blood Parasites, and chair of the British Committee for Standards in Hematology Transfusion Task Force, and a founder member of the British Blood Transfusion Society and their president from 2005 to 2007. Is that all of those details correct?
That's broadly correct. Didn't quite catch the earlier bit about the ethics committee, I think you said.
SNBTS Ethics Committee, Clinical Research and Investigations.
I've forgotten that.
July 1986.
That's correct, yes.
And you also provided both written statements and oral evidence to the Penrose inquiry.
I did, yes.
So if I can turn now to your role as senior registrar and senior lecturer at the London Hospital. So that was between 1971 and 1975. Can you tell us a little about your role in those posts over that time?
Well, as senior registrar, I was still trainee. So consequently, I was learning my trade and also preparing for the qualifying examinations for the Royal College of Pathologists. And also I was both at the St. Thomas's stage and later, I was preparing an MD thesis, which got accepted in 1974, I think. So I was training, studying, learning my trade, treating patients, learning the laboratory technology in hematology technology, which included cross-matching of blood compatibility testing and assaying clotting factors such as factor VIII.
And there was a haemophilia centre there under the directorship of Professor Jenkins. Is that correct?
Yes, he was not professor then. He became a little later, but yes, he was the head of Department of Hematology at the London Hospital, and indeed was was my boss, both as senior registrar, and then when the university granted academic status to the hematologist, he became the professor. He became George became the in charge of me as senior lecturer.
And were you...
Sorry, that was a little bit garbled, but you're correct.
And were you providing clinical care to people with haemophilia during that period?
there were some incredibly good and very cooperative haemophilic men who were patients in that unit. So I was both seeing them as outpatients and as inpatients.
So you had experience, did you, at that stage of administering cryoprecipitate and factor concentrates?
Indeed. In fact, my very first experience of administering cryoprecipitate goes back to my houseman days in Portsmouth in 1966-67, when there was a patient presenting with horrendous bleeding from his bladder, which is due to a cancer, and he was a haemophilic. And at that time, cryoprecipitate had just been discovered, and the hematologist at Portsmouth, Dr. John O'Brien, was able to procure large quantities of plasma for cryoprecipitate production from the Royal Navy base in Portsmouth. So I had my early experience in cryoprecipitate then, but I knew about it when I learned more, when I became a trainee at St. Thomas's and actually helped prepare cryoprecipitate at that time.
Now, your witness statement tells us about your work in this period, that you began to expand the service to local haemophiliacs. I wonder if you could just tell us a little bit about what you meant by that.
Well, we hadn't quite got as far as home therapy, although that was beginning to develop among the haemophilia consultant community. But we were just able to procure more cryoprecipitate from the Brentwood Transfusion Centre, and also just to make available more treatment, so that there were people who presented to us, some of whom I can remember very clearly, who were treated effectively as inpatients for their bleeding disorders, and that included some really quite difficult cases who required surgery. So we were able to support them mostly as inpatients from the London hospital.
And you've also recounted an incident in your witness statement of a patient who, after receiving one batch of commercial product, was infected with both hepatitis B and non-A.
That is correct.
Can you just tell us again a little bit about the circumstances in which that incident arose and the impact it had on you?
He was a 50-year-old man with mild haemophilia, about 5% of factor VIII activity, who had not really had very much problem with haemophilia, although he knew it all his life, that he'd had it. He'd had 3 other brothers who were also affected. And he presented on Christmas Eve with a raging toothache and an abscess. And this was bleeding, and there was no doubt that he needed to have urgent treatment, which involved the extraction of the tooth. I'm not sure if he was actually admitted, but he was certainly spent some time in the hospital. We gave him, we felt that cryoprecipitate may not be sufficient to control the bleeding. And in fact, I think there was very little cryoprecipitate in the hospital at that time. So we delved into our small stocks of commercial factor VIII, which I cannot remember the exact variety, but it was there available. We got him up to 100% full activity. The tooth was extracted without a problem. The abscess was drained successfully. The antibiotic course was successful, and he went home and had a good Christmas. About 2 months later, he presented with a rash and mild jaundice, and in fact, we didn't give him any treatment. He was mildly affected, mildly symptomatic, and went home and recovered. He then had a recurrence about 2 months after that, and I contacted Dr. Krask at Manchester, and he was able to inform me that he probably had both forms of what was then called serum hepatitis. One was probably hepatitis B, and I think we were able just to check that. But the other form was neither A nor B, and was my first clear-cut experience of non-A, non-B hepatitis. He recovered, and for the rest of the time I was at the London, he was no problem. I do not know what happened to him. It's possible that Dr. Colvin, who is my successor, may have some knowledge of that.
And your witness statement suggests that that incident had an impact on your later practice. Is that right? Can you tell us about that impact?
Well, particularly when I went to Liverpool, I mean, in fact, it was probably not very effective. But going to Liverpool and being aware, not least through the World in Action tainted blood program that came out in 1976, I think, that I was very anxious not to purchase American blood products. But if there were blood products, there were products available on the market that were, the claim was that they didn't come from American donors, although they did come from European donors, basically in Austria, who were paid for their donation, but at least it wasn't American. So in that sense, I tried to avoid the risk of using American plasma with its, by then, well-known association with the transmission of disease, and tried to avoid it by giving Austrian. In fact, we were let down because within a couple of years, a patient who'd received that Austrian product actually developed hepatitis in Liverpool. So consequently, that was a vain tactic, but at least I tried.
So moving on then to your time in Liverpool, so just reminding ourselves that was 1975 to 1980. I'm going to ask you, first of all, a few questions about the arrangements and setup of the centre itself. Were you the centre director, or was Professor Bellingham the centre director? There's different documents name one, either, or sometimes both of you as centre director.
And that's understandable. Professor Bellingham was the head of department and therefore took nominal responsibility for the care of the haemophilics. But he delegated that entirely to me. So that, for example, the purchasing policies, the clinical management of the haemophilics he presented was my responsibility. Of course, there were times when I was away, so either he or for the first couple of years of my time there, the other senior lecturer, Dr. Michael Leyland, would take over my clinical duties while I was out of hours. But apart from that, I basically ran the haemophilia service and filled in the returns for the director's organisation.
What region did the haemophilia centre cover?
Merseyside and North Wales. So it went from the boundary between Merseyside and the Manchester. So it went from Stockport on the in the north through to the Welsh Peninsula, including Bangor hospitals. So we actually had a significant population from North Wales as well as those in Merseyside. So that it included St Helens in Lancashire, as well as North Wales, and as I say, the rest of Merseyside.
Is it right to understand that Liverpool, the haemophilia centre in Liverpool, was not a reference centre? Your reference centre was the Manchester centre.
That is correct, and we had occasional dealings with that, although most of the time we were able to function separately.
And that's my next question. What did, if I can put it this way, your reference centre do for you?
Well, it was another forum for discussion and sharing of problems and understanding. And they were professional, helpful colleagues. So spreading the burden of responsibility was welcome to me. And there were one or two episodes involving a slight confusion among some of the North Welsh hospitals, I think Wrexham in particular, who clearly thought that if they had a problem with a local haemophilic, which was rare, they tended to turn to Manchester, I think possibly because the laboratory staff there had more experience of the Manchester setup than the Liverpool setup. But so there were occasional cross-references, but they weren't very often. And I was able to go to the Haemophilia Directors Organisation meetings, but not to the meetings of the reference centres.
And in terms of those discussions with your colleagues in Manchester, were those formal meetings, or was it more a question of picking up the phone when you got a problem and asking somebody for a view?
It was a mixture, but there were formal meetings. I think, actually, to be honest, there were only 2 or 3 meetings during my time there. The rest was by general conversation. And of course, we would meet at other functions like annual meetings of the British Society for Hematology. So there was a certain degree of informality as well as formality.
Is it right to understand that most, if not all, children with haemophilia in the Liverpool and Merseyside area were treated at the Alderhay Hospital?
They were treated. You use the word all. There was an understanding that as boys became teenagers, they were probably in some ways better dealt with in the adult unit rather than the children's unit, although it was a bit of a mixed blessing. Some of those young men were quite challenging, understandably, and it was felt that, and I went along with it, that they would be, as they were growing older, it would be better for them to develop links with the adult centre rather than say, with a children's centre. So the age differentiation was a little bit vague. Somewhere between 14 and 18, a boy would transit from Alderhay to the Liverpool Royal Infirmary. But we held joint clinics with John Martin, who was the consultant paediatrician in care of the haemophilics at Alderhay. And so there was, I think, a good understanding of the transition, those boys who were transiting from being young boys to young adults.
And the joint clinics were in respect of all of the, all ages, or with the joint?
Those were joint clinics for the children. So, so John would bring along his nurse specialist that he would work with, although I think her time was not fully time with the haemophilia. He'd also bring along a dentist, and we had access to social workers, physiotherapists, occupational therapists. So it was a sort of combined clinic. And in that sense, it was really quite advanced. It was really good thinking on John's part to actually bring in all the professionals who were dealing with these children who were growing up, and it was a joy to work with them. As adults, I ran a service which was also in conjunction with the physiotherapists, occupational therapists, and social workers. And of course, we had nurses on the wards who were particularly skilled with dealing with patients with haemophilia. And so it, again, was a sort of combined service, multi-professional in a way, which was important for these people, but particularly important for the children as they were growing up.
And in terms of the staffing of the centre, were you dedicated, was your role entirely taken up by the centre?
By no means. I would say that my haemophilic commitment was about 10 to 15% of my time. The rest of the time I'd be dealing with the clinical and laboratory service. I was actually the consultant for the laboratory services, which included the blood bank, the anemia services, the leukemia laboratory diagnoses, all those aspects, as well as the haemophilics. So the haemophilics were a very important part of my job, and that's why I was pleased to move to Liverpool. But I was by no means they were by no means my only commitment. It would be fair to say that sorry, I've slightly lost my thread, but it would be fair to say that my commitment was, because of my interest in calculation as a whole, my commitment spread a little bit beyond the haemophilics, and indeed included the Liverpool School of Tropical Medicine, which was next door, which was also interested in disorders of hemostasis because of the snake venoms with which they specialized. So my time, I was very interested in hemostasis, Haemophilia was a big part of that, but there were other aspects which I would explore too, which was helpful in the sense that it gave me a broader insight into the general nature of hemostasis problems.
And so is it right to understand that there would have been no dedicated haemophiliac, dedicated nurse for the centre or junior member of staff?
That is actually what I was slightly stumbling over now. There was no specific building or room with a door that said on it Haemophilia Centre. The services were provided, and I think I could describe myself as the director of the haemophilia services to Liverpool, but the site was split. There was the specialist laboratories, part of the laboratory block in pathology. There were the wards, and there were the outpatients where I would see the haemophilics. So the function was split over several sites, and that persisted when we moved to the new Royal Liverpool Hospital in 1978-79, which incidentally was a very disruptive experience. So consequently, my time was, and that of Professor Bellingham, was spent very much on coordinating the move of the laboratory and clinical services from the old and rather decrepit site to the new, better site, but there were still problems on the new site as well. So we had a lot to contend with, but the haemophilics were an important priority for me.
And we see a reference in some of the documents to people with haemophilia being treated on the tropics ward. Which hospital was that in? Was that in the old or the new or both?
The old, obviously, the old Liverpool Royal Infirmary, and it was called Tropics because in the first part of the 20th century, the school, the tropical medicine school next door, would attract people who'd been overseas and caught horrible diseases like malaria and others, which had a profound effect on the blood. So when they were admitted to this really rather wonderful ward, which was of a unique design. It was circular, and the 20 beds were spread around the edge, and they were pointing towards the pillar in the middle. That was partly to dissipate the risk of transmitting infections from bed to bed, like the old Nightingale model, but this was a different model. And they were the preserve of the physicians who specialized in tropical diseases. As time went on, the incidence of tropical diseases needing inpatient care declined, while the development of other services in hematology expanded, not least the blood bank, and then later the haemophilia disorders, but particularly the leukemia disorders. And so Tropics Ward was effectively the ward, the clinical hematology ward, which included leukemias in particular and some haemophilics.
Did you have a relationship with Dr. Robb at the Boulton Community Hospital?
I knew her quite well at one stage, but there was never any real dealings with, as far as I remember, with the haemophilic community.
I'm going to look now at the annual returns and with you. I'm going to look at two of them, 1977 and 1979. The inquiry has had a presentation on Liverpool and has looked at more than that. But if we start with 1977, that's HCDO 301178. And if we start, please, on page 14. We can see at the top that says annual return for 1977 for Liverpool Royal Infirmary, and you're noted as the director, along with Professor Bellingham. And we can see there that the number of patients treated that year were 56, none with factor VIII antibodies, Christmas disease patients 8, none with factor IX antibodies. And then if we look down at the table, we can see that there was no treatment with plasma. Can we have the whole table up? Thank you. Cryoprecipitate was approximately 800,000 units, and then NHS factor concentrate just over 13,000 units. No Abbott factor, some Armour factor, 58,000, quite a lot of Coate, 207,000, some Highland hemophil, and some immunocryobulin. And then we can see there the NHS factor 9 concentrate at 244,000 units. Just trying to understand that then, we can see relatively little NHS factor concentrate being used in 1977. Why was that?
Well, firstly, the handwriting is mine, so I can take clear ownership. The relative reduced amount of NHS factor VIII was simply because it wasn't available in the quantities which we would have otherwise required. So we were reliant mostly on the cryoprecipitate, and you can work out that from there, I've assumed that each pack of cryoprecipitate had about 70 international units. That's the maths. Had about 80 international units. That's the maths. Later on, I think I assumed there were more like 70 units. So that's, as far as the cryoprecipitate dosage is concerned, that is very much approximate, depending upon how much factor VIII was in each pack. And that could vary a lot, between about 20 and 100 units. So that's an approximation. But the others are clear-cut numerals relating to the amount of international units that those were given. An international unit being the amount of factor VIII in 1 ml of plasma, basically. So that's the sort of activities that they were given. And yes, there was a lot of immuno. That was as far as I remember, that's the Austrian product. And that's what I was using mostly of that year. But I was already beginning, as you see, to spread to the others, basically to spread the load and make sure that we had enough factor VIII in stock to allow for emergencies. The smallest amount there, hemophil, is the product that was manufactured by the company that was most criticized in the World in Action program. So that's a small quantity compared with the amount of cryobilin. But I do admit that there was a real mixture of origins of the factor VIII that was given.
I think you may be in error in suggesting that the biggest commercial concentrate usage was cryobilin, because I think, if you look again at the figures, the Coate is 207,330 units, isn't it? Have I got that right?
You are correct.
So
you are correct.
It looks as though Coate was essentially just under half of the commercial concentrate being used.
That is correct, Sir Brian, and indeed the number of bottles would confirm that that was the dominant factor that I was using in that year.
And the policy you've explained of the rationale, if I can put it that way, behind the policy of having this spread of different types of commercial product was to ensure that you always had a supply. Is that right?
That's correct.
Because there was a concern that if you just had one commercial concentrate, that it may run out and you may not be able to get a replacement.
That was our thinking.
If we then turn to page 15, we can see. That is the annual return for Christmas disease, but that shows as nil. That's carriers. I didn't mean to go to this page. I actually wanted to go to page 13. Sorry, could we go to page 13? Which shows the von Willebrand's. Here we go. So we've got summary of patients treated 1977 for von Willebrand's disease. We've got 3 patients there. We can see that they were treated primarily by cryoprecipitate, but a small 2 bottles of immunofactor 8 concentrate used in 1977. Can we then turn to page 9, because we get some information about the home treatment programme in 1977. So again, if we look at the top of that page, total amount of material supplied during 1977 to haemophilia A patients on home treatment. And we can see there that you have 330 bottles, approximately, I think that says 23 or 28,100 units you've estimated.
I think it's 23,000 if you apply the factor of 80.
Yes, thank you. Just pausing there. So you had a home treatment program in 1977 in which patients used cryoprecipitate.
That is correct. Could I just go back to your previous one about the von Willebrand's patients? That treatment was dominated by one individual. The 2 others received small amounts of treatment for bleeding episodes, but one individual based in North Wales who had severe von Willebrand's disease was bleeding from his vocal cords, and he required a lot of treatment, and eventually we managed to control it with large amounts of cryoprecipitate. The small amount of clotting factor concentrate he was given seemed to make no difference. So that was why so much was given in that unique circumstance in that year. Coming back to what's in front of me now, yes, you correctly point out that we were giving some cryoprecipitate to patients on home therapy.
And then we can see a small amount of NHS factor concentrate given as home therapy. Again, the reason for that was because of the limited amount of NHS factor concentrate. Is that correct?
Correct.
And then we see a range of different commercial concentrates being given as part of the home therapy treatment. Were there, and then if we look at the bottom of this, below this table, we can see comments. These figures include all patients from Merseyside, including children who are normally treated by Dr. J. Martin, either at Alderhay Children's Hospital or at the Royal Liverpool Children's Hospital. There is also one patient included from North Wales under the routine management of Dr. T. Com, is that?
Korn, K-O-R-N.
Yes. And so that reflects what you've just told us about the arrangements with those centres. So the numbers that we see, the number we saw of patients treated in 1977 by a Liverpool Royal Infirmary of 56 includes, does it, the children at Alderhay and the North Wales patients?
Yes, and that one patient was the man with von Willebrand syndrome, who was mostly treated in the hospital, but he may have received a little bit of cryoprecipitate at home, but I can't confirm that at this stage. My memory is not too clear on that point, but I actually do remember the patient very well because he was a very significant problem.
And I don't think this form helps us, this document helps us with home treatment for von Willebrand's, but we do get some information about home treatment with, beg your pardon. Yes, sorry, we do get some treatment for patients on home treatment with haemophilia B or Christmas disease. If we look at page 11, we can see their total amount of material supplied during 1977 to haemophilia B patients on home treatment. We can see it's all NHS factor concentrates. no commercial products used or other products used.
That's correct.
You tell us in your witness statement that during your time at Liverpool, the number of patients on home therapy increased from 15 to 27. Was there a policy of trying to get more patients on home treatment during this period?
Yes, I was committed to expanding the already established home therapy program.
And can we then look at the last page I want to take you to on this document, at page 1, please, which gives us a breakdown of the treatment by patient, for each patient. And the patient's names, which have been redacted, and dates of birth are on the left-hand side. And then we can see various bits of information about their condition. And then we have on the right the type of material received during 1977. And we can see that for many of the patients, they received a number of different types of commercial concentrate during 1977. Is it right to understand from looking at this document and the following pages that there was no policy in 1977 of trying to keep patients on one type of commercial concentrate?
Yes, that's correct.
Can we then turn to the 1979 a return, which we find at HCDO 0001344. And we can see at the top annual return for 1979 for treat patients with haemophilia or Christmas disease, RLH, the move to the new site, and the director this time is noted to be Professor Bellingham. Total number of patients treated during the year is 49. Now, the previous year it was 56. Can you help us with why there's been a reduction over the 2-year period of 7 patients?
This return was made by my successor sometime in 1980. But I had taken care to prepare most of the data before I left, so that my successor was not left with the need to go through all the paperwork involved in filling out this data. So by the time this was returned, Alistair Bellingham was in effect acting as the director, at least nominally, but I think that my successor would have taken on much of this work. So that's why my name is not there. I wasn't there at the time of completing this return, but most of those figures were worked out by myself. As for the reason for the reduction in treated patients, that's just chance, I believe. So some years it would be in the high 40s and other years it would be in the low 50s. So I don't think there's any great significance in the change of numbers of patients treated.
And we can see their number with factor VIII antibodies 2, total number of Christmas disease patients treated 5, and none with factor IX antibodies. And then if we look down the page, we can see that there's a figure for the cryoprecipitate whole region of about 18 million units. You didn't fill out this form. Can you help us at all with what that means?
Sorry, could you just repeat that again?
The first entry on the table is cryoprecipitate whole region, and then we've got cryoprecipitate RLH only. Can you help us at all? I understand you didn't fill this out, but can you help us at all to understand what whole region might mean?
Well, also that top line is deleted by whoever prepared it. So I can't give a clear explanation of that.
And then we've got...
I think the fact that it's deleted implies that it was actually an error.
Cryoprecipitate RLH only, 630,000 units. NHS factor 8 concentrate, 220,000. Armour factor 8 concentrate, 550,000. Highland, a small amount, 750. And Immuno, 150,000. And then at the bottom, there is brackets Oxford, 177 bottles, approximately 115,000 units for Christmas, for haemophilia B Christmas disease. And then other materials, it says DDAVP. Just pausing there on the DDAVP, that is the first time we see DDAVP entered onto the annual returns. Can we take it from that DDAVP would not have been used before 1979?
No, we were using DDAVP. It became available, I think it was licensed for treating haemophilics in about 1976 or 77. And I remember presenting the ability to treat mildly affected haemophilics and people with von Willebrand's disease with this desmopressin or DDAVP, which could be given by injection and would induce an increase in the level of factor 8 and indeed of von Willebrand's factor in the blood of these mildly affected patients or patients with von Willebrand's. So I'm sure I was doing that from 1977. I think the haemophilia returns did not request data about DDAVP until this particular year. So I may well not have documented for my successor how much DDAVP was used, and so he would be unable to actually complete that detail. So that form is a slight victim of a handover, which might have been better, but I was doing my best to ensure that all was accounted for before I actually left.
I'm going to ask Sally, please, to put this, keep this page on the screen and to go back to the 1977 document and have it next to it so we can see how the prescribing practice has changed between 1977 and 1979. So Sally, could we please have next to this page 14 of HCDO 0001178. So I hope you can read this, Dr. Boulton, but we can see, we just looked earlier at the cryoprecipitate from 1977, approximately 10,000 bottles or 800,000 units. And we can see that that's reduced somewhat by 1979 down to just over 7,000 bottles or 630,000 units. We can see that the NHS factor concentrate has gone up from 13,000 units to 220,000 units. Can you tell us the reason for that?
I believe that BPL had expanded their capacity to prepare factor 8 concentrate from English donors of donations of plasma. So as a result of a building program, they were able to supply the whole country with rather more factor 8 than they had in earlier years. So I think that's the explanation.
And then we can see that there's a rather different pattern of, well, perhaps not very different, but rather than having 4 commercial concentrates in 1977, there are 3 commercial concentrates, although one is the haemophil is a small amount, and it's primarily factor VIII at that stage with some cryobilin.
Yeah.
Again, was there a different policy by 1979 in terms of spreading the concentrate across different manufacturers, or was that just a matter of chance?
I think we were becoming more aware of the need to be a little less liberal in the resourcing. Each commercial firm was charging roughly the same amount. I think it was 10p per unit of factor VIII. So it wasn't so much a price difference, although there were occasional tussles that would try to make one more attractive than the other. But the other thing that was of significance, and I cannot remember the details, but the haemophilics themselves, or their mothers who were treating the children at home, really liked the stuff that dissolved most quickly. And some of these preparations, particularly those in 1977, did not dissolve all that well. And so the same manufacturer would produce improved batches that dissolved more easily. So some of this may have been slightly driven by the preference of the patients or their parents in terms of the convenience of dissolving the powdered material that was kept in their fridge at home in water that I advised be not kept in the fridge, because cold water didn't dissolve things as well as water at room temperature. So there are a lot of those little details, but some of that difference might have been due to patient preference, and it looks, if that's the case, that the one product they did prefer was the Armour Factor VIII.
And then just looking at the amounts, by my calculations, the 1977 number of units for commercial factor concentrate across those 4 that we see there comes to 457,320 units. And by 1979, that has increased across the 3 commercial products we see there to 920,750. So I don't expect you to be able to do the mental mathematics on the spot, Dr. Boulton, but we can see, looking at it, that there's. Sorry, I think I've got that figure wrong.
Yes.
I beg your pardon. I think that's the whole. That's the whole of.
It's 700.
Yes, thank you.
Yes, it's 700,750. If you add up those 3.
It is, and the figures that I gave you, I beg your pardon, were not just for commercial concentrate; they were for concentrate altogether. So the 457,320 was for all the concentrate, including the NHS factor, and the 920,750 was for all the concentrate, including the NHS factor concentrate. So. The question I have for you is it right to understand that between 1977 and 1979, there was quite a considerable increase in the amount of factor concentrate that was being prescribed by the centre?
That is correct. And it would be related to the expanding home treatment programme.
So I'm going to ask you now some questions about the policies and the rationale for those policies and how you made treatment decisions. First of all, I'm going to start on the home treatment programme. What criteria did you use to decide which patients should go on home treatment and which patients should not get home treatment?
Well, I personally trained the patients or their parents, usually their mothers. So that would involve physical face-to-face meetings, discussing, first of all, the pros and cons of home therapy, and discussing the practicalities, like did they have a refrigerator? What were the conditions like? I don't think I actually visited their homes, but that was an option that could be done if necessary. But it involved a lot of close conversations with the people affected, and in a sense, just to get a feel of how suitable they were, how well they could cope. Needling veins is always a challenge, and you can imagine that for a mother faced with a 4-year-old, 5-year-old little boy, learning to put the needle in the vein is a very stressful experience. They were very well motivated, and they, on the whole, learned it very well. But there needed to be care in the process of training, advising, and I had to be reasonably satisfied that they were able to cope. I do remember one occasion with one young man, I think in his early teens, who said he couldn't dissolve the factor VIII in the vial. And I found out that actually because he was warming the water and basically cooking the factor VIII as he put it in. So that's the sort of thing that would be dealt with in the course of training these people. So that was quite a lot of time spent doing that. But on the whole, it was worth it. And in terms of the relief of access of pain and difficulties, although more factor VIII was used because of the home therapy program, what was used is probably used more effectively in cutting short the time that the people were actually bleeding. If you're bleeding into a knee joint, very painful. If it took an hour or two to come to the hospital, prepare the cryoprecipitate or factor VIII and administer, there were still a few hours of quite intense pain. At home, the patient would say, I've got something in my knee, I know it's going to bleed. And they would be able to treat it much more effectively. And so consequently, although more was used, it was also used more efficaciously. So the training program was important in order to develop. So consequently, I did develop a fairly close relationship on those terms with the patients and their parents.
So it were all the people on home treatment severe haemophiliacs?
Sorry, I missed a little bit of that.
Were all the people on home treatments people with severe haemophilia?
Yes, yes.
And what about people with moderate haemophilia? Would they be put on home treatment?
I don't think I offered home therapy for those moderates. We're having a distinction here, aren't we? Whereas the severe, less than 1%, the moderates sort of up to 5%, and the milds more than 5%. As far as I remember, but I can't be totally accurate on this, none of the mildly affected haemophilics actually needed home therapy in one sense. But it is possible that a few of the moderately affected might have done, but I cannot remember. It was principally directed at those with severe haemophilia.
Can we just look at a document then that you wrote to Dr. Martin about home treatment? So that's WITN 0173002. It's a letter that you wrote to Dr. Martin, and when it comes up, we'll see that it's dated the 29th of October 1976. Could we go to page 4, please, of that document? And we can see at the second paragraph down, because of recent queries from the Central and Southern District Administration concerning the expense of buying commercial clotting factor concentrates, I feel that wherever possible, we must initiate home therapy program on the basis of cryoprecipitate. Mrs. X has a deep freeze, but is not sure of its temperature range. However, if this turns out to be satisfactory, and of course the BTS will have to be satisfied with this, I think we should encourage her to continue on the basis of cryoprecipitate at home, although we can get powdered concentrate for travel. I have not made a further appointment, but have asked Mrs. X to bring.
Just pause there. We've lost the bit on the screen because of the highlighting.
I beg your pardon. Sorry.
Sally, can we move the? Thank you.
Thank you, sir. I have not made a further appointment, but have asked Mrs. X to bring, presumably her son, to Tropics on the next bleeding occasion, so that I can be satisfied that A, she can needle properly, and B, she is confident about reconstitution of cryoprecipitate. So we can see from this that the process of you consulting with and Dr. Martin in relation to a child patient. Is that right?
That is correct. Can I just offer my profound apologies for the somewhat maladroit wording of the first paragraph? Those are words which I would not use these days about people having slight histrionics. So I regret that particular use. It was not appropriate. This was a lady who was clearly concerned for her son, who was then, as I say, a remarkably lively little chap. So clearly I warmed to him as a person, as a little boy. And she was exhibiting the very straightforward and understandable anxieties about the future of her son. So on behalf of us as professionals, I would say I regret that wording. Of course, it's quite extraordinary how one's past catches up with one, and something you think is confidential will never be revealed to the public. That's a lesson that I think is very profound for the whole of this inquiry. The amount of confidential material that was inappropriately confidential and which hampered communications was quite profound. But I do apologize for that. As for the rest of the letter, I only saw this a week or so ago, and I have to say that apart from that first sentence, as far as this letter is concerned, I was quite gratified to be reminded of this particular episode, which I had otherwise almost completely forgotten. And it's rewarding to have even a little bit of feedback from a patient, even though, as I see from the rest of the document, it was the beginnings of a really rather tragic experience for this man. But nevertheless, it did confirm that we were training people to give cryoprecipitate at home, although I developed reservations about that later on because of the nature of the material and of the alternatives that could be given. But in those days, when there was very little NHS factor VIII around, if one had to give factor VIII, it was either commercial or cryo. And cryo was obviously, at that time, an option I preferred for certain types of people, and that included this mother and child.
And you set out there that the pressure, if I can put it that way, on you as a prescriber in terms of paying for commercial clotting factor, and that.
Yeah, we were given a budget, and it was a fairly tight budget, and I was very keen to keep to it. And the budget was about £40,000 a year to buy commercial factor VIII. And I think in that particular year, I spent £50,000, and the treasurer was actually pleased that I hadn't spent any more. He was expecting a hugely bigger sum, but we were trying to keep within reasonable bounds. But nevertheless, there were financial constraints, and that's a reason why for certain patients, I felt the cryoprecipitate was a good option.
So you were reserving the more expensive commercial concentrate for this patient for when cryoprecipitate really couldn't be used for travel and so on.
I think that's right. I mean, children would respond. I mean, you didn't need to give much cryoprecipitate in terms of volume to a child. So that child would only be exposed to the number of donors who contributed to that cryoprecipitate pack, which might even be just one or maybe two or three people. But as they grew up and their blood volumes got bigger and they needed much bigger doses, it was one was sometimes forced to use materials that they could inject more easily because the concentrate was made up in much smaller volumes of water, so that an adult may only need to inject 10 or 20 mils of liquid that was contained commercial concentrate compared with the equivalent volume for factor VIII content of cryoprecipitate. So children were more tolerant in a way of receiving cryoprecipitate, but as they got older, needing more, we had to resort to the more concentrated forms of commercial concentrate.
And can you recall how many of your patients you had on home treatment with cryoprecipitate?
I can't recall with any accuracy. Seeing this reinforced what is on the earlier displays that you showed, that cryoprecipitate was being used, but I cannot remember how many patients. It was probably not a large number, by which I mean half a dozen or so, I think. But I have no clear memory of how many people I would be treating with cryoprecipitate at home.
And for those patients that you consider to be appropriate to and would be able to manage cryoprecipitate, did it work reasonably well as a method of home treatment?
Well, I think it's the patients and their parents themselves who are more qualified to answer that question, mainly because of my lack of memory. But the fact that it was documented in the returns of 1977 that we were doing it, as well as this particular child receiving it, confirms that some people were able to use it, and presumably with some satisfaction, although I think it wouldn't be surprising if sometimes we had to resort, even for those children, for concentrates. And I think that's what happened to this particular boy.
Now, you've just told us that one of the factors that was important when deciding whether a patient should get cryoprecipitate or factor concentrates was the age of the patient. Were there any other factors that you took into account when making that decision?
Well, apart from the social circumstances that the child or their family or the patient were actually living in, which was quite an important factor in advising how to care, I think probably the cryoprecipitate was more reserved for the smaller people, which would be basically children.
And what about when you were making that decision for a treatment for a patient that was coming into hospital for treatment, so somebody that's not on home treatment? What factors would you take into account when deciding whether or not to give them cryoprecipitate or factor concentrate?
Well, I think cryoprecipitate was preferred for most of those who attended the hospital, either for a day treatment or for admitted for several days. Those circumstances, although I've described it was time-consuming and people would be in some pain, if we heard in advance that the patient was coming, we would have time to start thawing and preparing the cryoprecipitate in advance. So consequently, we would be able to prepare the cryoprecipitate ready for them to use, to be given. And also, we ourselves were reconstituting the cryoprecipitate under controlled circumstances. We ourselves would be putting the needle, although sometimes the patients still preferred to needle themselves once they'd got expert at doing it. So, but it was done under more controlled circumstances in a health setting, which which lowered the threshold, if you like, for using cryoprecipitate. The other thing about cryoprecipitate that is important is that it was accompanied by a significant frequency of adverse reactions, mostly fever and headache. And somehow the children seem to be more resilient, I think, for this. whereas the older children and adults were more prone to having these adverse events. And it was much easier to deal with those adverse events when they were actually in the direct care of the nurses and doctors administering the factor VIII. So in many ways, cryoprecipitate was reserved for hospital care because we could keep a closer eye on the circumstances of the actual infusion. Whereas at home, we would be less able to keep a close eye. That would have required a standard of training, a standard of trust, a confidence among the parents that they were able to infuse the cryoprecipitate, and a confidence among the parents that they were able to infuse the more concentrated factor VIII and in dissolving it and preparing it for infusion. So it's quite a long and complicated process. It's not just an easy thing to say home therapy. It involves an awful lot. And actually, Peter Jones's book on living with haemophilia was immensely helpful in that particular regard.
When you're faced with a patient who you want to treat with concentrate, what criteria did you use, or how did you decide whether or not that patient should get commercial concentrate or NHS factor concentrate?
Well, and I think this mostly applies to the latter year, because that's when we had a more substantial amount of NHS factor VIII. One important thing is, why were they admitted? If it was for surgery, and we were there were patients who required surgical episodes, either urgent or planned. The occasional orthopedic surgeon would be required to do something for a patient for a hemophilic joint. Under those circumstances, we required large amounts of factor VIII, and the most readily available sources would be the commercial. For other episodes, for example, dental extractions that could be done at home, these dental extractions that could be done in an outpatient department of the hospital or the dentistry, we would possibly give either NHS factor VIII or cryoprecipitate, accompanied by antibiotics and also antifibrinolytic agents to stop the clot dissolving. So in those circumstances, we might be able to avoid the use of commercial factor VIII, but quite honestly, I cannot recall any details. These are something of a supposition from what I can recollect about what our general policies for treatment were at that time. And I don't think we can place too much reliability on what I just said about whether we would choose to use NHS factor VIII or commercial factor VIII. But clearly there was more commercial factor VIII around, and so consequently they were used for patients as a sort of second resource, with the NHS factor VIII being the first resource of choice. But I cannot make an accurate comment on those policies going back 40 odd years.
And did you introduce a prophylactic program of treatment at Liverpool?
No, I didn't. I know that they were advocates of home therapy, but I felt that of prophylaxis and home therapy prophylaxis, but I felt that the home therapy program was adequate in aborting the early stages of a bleed that the patients knew was going to be painful. And that was not a form of prophylaxis, but it was a form of treatment, a preventative treatment, stopping an established bleed getting bigger. But I did not introduce a prophylactic program in which patients who were not experiencing a bleed would nevertheless inject themselves with enough factor VIII to tide them over the next few days, so that if they did have some sort of accident, their blood would clot normally within them. I did not do that as a prophylactic program.
So just drawing this together before we break, can we look at a paragraph in your witness statement, WITN 3456002, page 28 of that witness statement, to understand what the treatment policies were during your time in Liverpool for people with mild haemophilia. At the bottom of that page, you're asked to what extent and why were people with mild or moderate bleeding disorder treated with factor concentrates. And then you say at paragraph 72, in 1977 of 10 patients, 1 had only DDAVP, 8 had cryo, 1 had coate. And if we go over the page, please. In 1978 of 5 patients, all had just cryo. In 1979 of 7 patients, 3 had just cryo, 2 had cryo plus DDAVP, 1 had cryo plus factor VIII, 1 had just factor VIII. I cannot recall the clinical circumstances. So from that, do we understand that certainly from 1977, the primary, the preferred course of treatment for somebody with mild haemophilia was cryoprecipitate and cryoprecipitate and DDAVP?
I think so. This data in my witness statement is based entirely on the returns, which we've already shown. So I really cannot add any more details to this description. So I think I have to leave it at that. But yes, for mild haemophilia and indeed von Willebrand's disease, when DDAVP became available, that was the matter of choice, as again, particularly if they needed a dental extraction, in which case we'd also give, as I say, antibiotics and antifibrinolytics. Saliva has got enzymes that dissolve clots, so it was important to try to inhibit that. So that was part of our treatment program, including DDAVP. I think that's all I can really say.
And again, drawing together what you've told us about those with severe haemophilia, is it right to say that it's not really necessarily possible to identify a first line of preferred treatment for all of those with severe haemophilia? It would depend on their age and their circumstances as to whether they should have cryoprecipitate or factor concentrates. And if they're to have factor concentrates, it might depend on their own preference or availability as to whether they have NHS factor concentrates or commercial factor concentrates, and if commercial, which commercial?
To be honest, I don't think the patients were offered much of a choice of concentrate. In other words, I don't think they had an opportunity to say, could I have the NHS one, please? Maybe that is regrettable, but for much of the time, there wasn't much NHS around until the last year. So it was a little bit of sort of Hobson's choice. But nevertheless, on reflection, it would have been good practice to have reserved the NHS factor VIII for some of the most needy cases for whom who perhaps didn't require treatment quite so often. That's a little bit of a contradiction, I realise, but there were some patients who were severely affected in terms of their factor VIII content in their blood, their factor VIII activity in their blood, but who didn't present very often. And if they needed therapy, they needed it properly. You couldn't go halves on this. And that's also true for people with mild haemophilia. If they needed a large amount of factor VIII, because DDAVP would only give a boost, and it wouldn't last, and you couldn't give it the next day. You couldn't give repeated courses of DDAVP. It was the first dose that was most effective. There's a sort of exhaustion effect of the sources, of the stores of factor VIII in the body. But patients with mild haemophilia, as far as their activity is concerned, if they started bleeding, they could bleed very heavily, and they needed quite a lot of factor VIII. So perhaps for them, the first choice should have been NHS factor VIII, but I cannot remember the details of my policy at that stage in 1979 in the Liverpool Haemophilia Centre. So I can only give general comments and not perhaps what I actually did.
So I note the time. It would now be an appropriate time to take a break.
Yes, it would. We'll take a break until 10 to 12. We're just starting a break, Dr. Boulton. Let me tell you what I say to all witnesses at this stage. It's this. You're giving evidence. You must not discuss anything you've said in evidence with anyone, your wife, anyone else. You must not discuss anything which you think you may yet be asked to give evidence about, but you can talk about anything else you like. I'll see you back on screen at 10 to 12.
Thank you very much. I take all those points.